But you have been doing by the normal knee with the normal jigs. No, you can't hear now. You can?
Well, I can hear. I've got a lot of static coming for some reason.
कोई और clear कर सकते हो इसको? Try to clear the mic. There lot of echo is there. You know the clear-cut advantages of robotics? No, okay. I think we write the question in the chat box because we are able to hear.
Was the question, what was the transition from mechanical to robotics?
Yeah.
Okay. So for me, I tried a number of different techniques. If you turn that microphone off, or for some reason my computer is just giving me a ton of static. It was off for us. There you go. Perfect. If you could leave it like that, then I can. Then I'll talk. But to me, when I did mechanic, I was trained at Mayo Clinic. We did measured resection techniques, and then I tried gap balancing for a while. I always found that balancing the flexion extension space, with mechanical alignment was resulted in a lot of soft tissue releases, particularly in tight varus knees, tight valgus knees. I find with robotics, because I know what the soft tissue envelope is doing prior to making any bone cuts, I would say 95% of the time after I make my initial set of bone cuts, the knee feels perfectly balanced. Now, sometimes I'll be within a millimeter of polyethylene. So, for example, you saw that case. I planned for a 6, I got a 7, or I might plan for a 6 and get a 5. And there is some error in the system. The systems aren't perfect. There's a half a millimeter error or so that's not unanticipated. But it's extremely unlikely that I'm going to make a set of bone cuts and then have to go do a big soft tissue release that I didn't anticipate. Now, there's still, tight 20-degree varus knees with bone loss, and you can see that in the soft tissue graph ahead of time. But the difference is now I know what to expect. So, for example, in a knee like that, I can plan the lateral side where I want it, and then I just know that I'm going to have to do a large soft tissue release to get the medial side to catch up to the lateral side. And I'm no longer ending up with thick polyethylenes or, altering the joint line or making second, third sets of bone cuts to get the knee balance. So I just find this technique very efficient in the operating room. I think my patients get far fewer soft tissue releases than I used to. And, I don't have great clinical data at this point that they're doing better, but we're starting to see some data coming out of the initial, we're about 5 years into our initial robotic experience, and we're starting to see lower rates of revision, lower rates of instability, and I think that all makes sense now. People are using robots you've got guys doing kinematic alignment, patient-specific alignment. Some guys are still just doing straightforward, mechanical axis with the robot. So people are using all kinds of different techniques, but the bottom line is a surgeon should know what you're getting, prior to making any cuts. So I can see this chat. So whoever's writing these chat questions, that's fine. It says, how do you decide the posterior slope of the tibia? So my default is 5 degrees of posterior slope, and I've tried playing with this in the previous system. That system was designed for 3 degrees of slope. So I've tried measuring it on a CT scan or an X-ray and then altering slope. I really haven't found it to be to help me a bunch. So in other words, if a patient has a lot of native tibial slope, and you cut it without, sometimes you'll feel the PCL tension and deep flexion. The insert that I use, I can release the PCL if needed, and the dish will accommodate that with the attuned system. The next question was the PCL tension assessed with the 2 elevators? Yeah, so that's been my experience. So the new software with this system, you don't have to. So the truth is, I don't typically tension each compartment individually. The initial software system had to go through an arc of motion and flexion to assess that gap. The new system does not. And so my technique right now is I'll put 2 elevators in at the same time and then tension the flexion space with the PCL intact. And so when I do that, then I know that I'm not, you know, collecting data that looks like a loose flexion gap and over-tensioning the flexion space. Does the saw automatically stop if it violates the MCL or LCL? It does not. So this is this system gives you a plane to cut, but you have to put retractors under the MCL. I've done about 2,000 knees robotically with the striker system. The issue you and actually that system has the same problem because it's based on a CT scan. Once you take the osteophytes off the tibia and femur, the CT scan is no longer valid. So if you just trust the CT scan and that model, you're still going to get yourself in trouble because what the computer thinks is there is you know, it's not there, and then the saw blade will exit into the soft tissues. So the way that I cut this with the leg in one position, you obviously have to be cognizant that you're protecting your soft tissue envelope. Also, the next question was whether it stops posteriorly. It does not. Rotation of the tibia. So next question is, does the system allow rotation of the tibia? Yeah, I mean, the surgeon still rotates the tibia internally and externally. The surgeon chooses the axis for the tibial slope during the registration process. So for me, I'll take the medial aspect of the tibial tubercle, and I'll put it back towards the intercondylar notch, and then that defines the slope of the tibia. So next question is, and this is a great question. It says, didn't notice in sublux the tibia, hence you can't remove the tibial osteophytes. Does this influence the ligament balance? And absolutely it does. So what you have to do, if you have a knee with a lot of posterior osteophytes, once you remove the osteophytes, the extension gap will open up, and that's on the femoral side and the tibial side. And so if I have a knee with a lot of osteophytes, the new generation of software, you do not want to collect the ligament tension at full extension, because what you're actually collecting there is the tension on that compartment with the osteophytes intact. So what I'll do is I'll go to terminal extension, and let's just say with a posterior osteophyte knee that it comes out to 10 degrees. So I will back the ligament balance up to 20 degrees, where I'm no longer tensioning the posterior osteophytes, but I'm tensioning the medial and lateral side. And you can see that on soft tissue graphs. So you'll see that the soft tissue graph towards terminal extension starts to tighten up. You're not actually seeing a tightening of the ligament. You're seeing what happens when it tensions against the posterior osteophytes. And in my experience, usually with small osteophytes, you're going to lose about 1 millimeter of tension, and with large osteophytes, you'll lose about 2 millimeters. So, but if you collect the data at terminal extension and then you make those bone cuts and then remove those posterior osteophytes later, what you're going to get is a knee that's loosening that compartment that have the osteophytes. You do have to take that into consideration. And some surgeons, and I think this is a very reasonable surgical technique, they'll cut the tibia first, they'll take the osteophytes out, try their best to get the posterior osteophytes off the femur and tibia, then do another ligament balanced sequence, and then make the final cuts on the femur and implant. I don't see a problem with that. For me, this technique, I've just done it a lot, and it's efficient. I collect one set of data, one set of bone cuts, and then go from there. The next question is, do you remove all osteophytes and do a limited release before proceeding to the next step? Hopefully that conversation answered that question. I do a very similar release for all my varus knees and a slightly less release on the valgus knees, and then go from there. I do sublux I didn't show in that video, but I do sublux the tibia forward when I collect the tibial points now, because I think when you sublux the tibia forward, you do get some soft tissue changes that, and when you put the final tibial component in, you have to sublux the tibia forward. And so you want to know what changes happen on the medial side when you do that. The next question is, if you need to make a change, plan intra-op, is there a bailout or do you start from scratch? Actually, the one thing I like about robotics is the changes are very easy. So, for example, yesterday in the operating room, we were doing these. I had one knee that I thought was tight in extension and a little loose in flexion by 1 millimeter or 2. So all you have to do is go back to the computer screen, plan to take another 1 or 2 millimeters of bone. You bring the robot will slide right back in. It'll make that set of cuts for the distal femur and the chamfer cuts, and you're good to go. So the intraoperative changes are fairly straightforward, and I think much easier actually than the way I used to do it, where I'd have to pin the blocks back up. What is the gap difference that you'd accept in the medial lateral side as well? Flexion extension for the cuts. So for me, the gap difference for me, it's an alignment issue. So I try to make my extension gap the same, and I flexion gap just slightly, about 1 millimeter looser posterior medial and slightly looser posterior lateral. For me, the gap difference that I accept is based on 4 degrees. So I don't program the computer or the robot to change the mechanical axis by more than 4 degrees. I think there's good data for implant survivorship as long as you stay within a 5-degree window. So for me, if it's a really tight varus knee or valgus knee, for example, I'll balance the loose side on the robot, and then I'll do a release to let the tight side catch up to the loose side. So in some cases, the gap difference will be 2-3 millimeters. In some cases, it'll be more or less than that. But I don't stray beyond 4 degrees of mechanical axis. Some people do. That's my 2 cents.
Any questions from the floor before we say thank you? John, can you hear us? John, can you hear us?
I can hear you, yeah.
Okay, thank you. Thank you for answering all our questions, and thank you for that good demonstration.
Sorry, I didn't hear that.
Thank you.
Oh, you're welcome. All right, guys, enjoy the conference. Have a great day.
Tati has to catch a flight, so he's going now. Let's say goodbye, and we'll be doing it with a memento, a bag made from Kanpur leather. The award list is now here, and Dr. Sanjay Agrawala, the patron of our society, will be giving the awards away. Who is first, second, third? ये तो दिखा दो मुझे. Marks. Oh, Dr. Amit Jaiswal. I'm starting with the first one rather than third one. The top. यादव है कि नहीं? डॉक्टर विनीत यादव. कल दे देंगे. ज्यादा अच्छा है. है कि नहीं? वर्कशॉप में थे उनके लिए हैंड्स ऑन के लिए पीएफसी पोस्टर स्टेबलाइज will be demonstrated by Dr. KG Tripathi and Dr. Anupam Srivastava. PFC cruciate retaining will be done by Dr. Vishwas, Dr. Rajendra and Dr. Manav. And a tune rotating platform by Dr. Arvind Prasad and Dr. Manish Trivedi. So you can go to the table, take hold of your faculty and ask them all the questions. And it can be checked by two things. Number one, this which is parallel to the child, this which is perpendicular to the...
Today, I think yesterday, day and night were wonderful. What's the opinion of the house? Sometimes, when ambitions overtake performance, the gap is called frustration. I am repeating it. When ambitions overtake performance, the gap is called frustration. But if performance overtakes ambition, it's called success. So I think last day, the performance of everybody was excellent, because the success of any conference or any course is with the delegates. And if their performance overtook the ambitions, it was success. And I hope so, we landed on that. The same scenario we are going to repeat today on a hip session, and we are starting with the paper presentation. I am requesting Dr. Sanjay Agarwala to accept, sir, to accept as a chairperson. I think you remain seated there. You are right, sir. I am requesting Dr. Dhanshekar Raja to be on the dais. Dr. Anil Omen. And we start requesting Dr. Adit Narula. The other person should load the case on the other side so that there should not be a gap on presentation and we save time. Because after the lunch, the faculties have to leave and everybody has to leave to Lucknow, to their places. So we have to save the time. And time saved is time earned.
Time last night, and I will be starting my presentation on this case of total hip arthroplasty in failed fixation of intertrochanteric fracture. Firstly, I would thank my mentor, Dr. A.S. Prasad sir, for helping me in this case throughout the planning, because if you fail to plan, then you're planning to fail. Let me give you a brief history. with intertrochanteric fracture, got operated the next day with PFN. This was the X-ray which she had after surgery, and she told me that she was walking normally with walker support for 3 months, and then she started having pain over the right hip for 3 months. And she was started with injection teriparatide by the index surgeon and was again mobilized after a month's time. She was walking with walker support for 6 months, and then she again started having pain at the operative site. With limp and inability to bear weight over the right lower limb. On examination, there was no neurovascular deficit. Abductors were weak on the right side and a palpable screw over the right proximal femur. This was the X-ray which I got in OPD, in which there was a Z effect and the screw backed out. The proximal screw was palpable and the other screw was broken inside the head. So what all options do we have in mind? I had told the patient about revision surgery with PFN along with plating and bone grafting, but I was reluctant to do that because there was lysis at the screw site and the head was more likely going into avian. And the other option which I gave was of a joint replacement. So patient wanted to go ahead with one-time surgery as chances of implant failure again post-fixation were clearly explained to the patient and chances of ABN were also told. Now coming to the planning part, to rule out any infective pathology apart from mechanical failure and to do it in a one-stage or a two-stage procedure. So I had read this paper in which there was a good functional outcome with total hip replacement using a distal loading femoral stem post failed fixation of a proximal femur nail, and so wanted to go ahead with total hip replacement itself. On discussing with mentors, I planned for a two-stage procedure. Stage 1 was implant removal and debridement. Had a serosanguinous discharge coming from the post opening the proximal femur side. There was serosanguinous discharge, and those samples were sent for culture and histopathological examination. After removing the proximal femur implant, the greater trochanter was completely mobile. So I temporarily fixed it with K wires and TBW, and so that we had good abductors over there at the time of total hip replacement. Now what next? Should we go ahead with a THR with solution or a Wagner stem or a long C-stem cemented THR? So this paper by Dr. S.K. Maria sir and Rajiv Fikral sir gave confidence to going ahead with a fully coated stem for a proximal deficient femur. They had shown around 15 patients in which they had good results in 14 of them. After 3 weeks, histopathological examination and culture were negative for any infective pathology, which was a good sign, so I can go ahead with surgery. I went ahead with solution stem THR. Things which I kept in mind were to cross the PFN distal screw side by at least 2 diphaseal diameter to prevent stress risers, greater trochanter fixation to maintain the abductor power, and she was a short female, so femoral bowing had to be taken into consideration. Regular intraoperatively fluoroscopy were taken to prevent overzealous reaming and piercing the anterior cortex. Approach was posterior lateral. At the time of removing the PFN, I made sure that I am not going more posterior and disturbing the anatomy of the total hip replacement side. So the methodology was greater trochanter was held with the opposite side smallest distal femur plate with unicortical screws so that assessment in anatomy became more clear in the approach. Regular images were shot intraoperatively to visualize if reamer has crossed distal screw side of PFN. The dilemma was the longest stem available on table was approximately 1.5 centimeter distal to the PFN distal screw side, and the calculated was somewhere around 3.5. So that was the risk I had to take. Plate was removed and greater trochanter was secured with number 5 Ethibond. with ample of bone graft harvested from the head and the reamed acetabulum. This is how the greater trochanter looked after fixation with ethibond. I had incorporated ample amount of graft at the fracture site. The problem came when, at the time of proximal impaction, there was splintering noted at the proximal femur diaphyseal region. So before moving in ahead, I had to circlage it to prevent more splinting. Luckily, went well after circlage, and this was the lesson learned, because at the time, in few papers, they had given it to already do a prophylactically circlage and then go ahead. This were the C-arm images at the time of surgery. You can clearly see this. One second. There was splintering noted over this region, and this was the PFN distal screw side. So the solution stem of 10 inches have surpassed the distal femur screw side. These were the C-arm images. On the left side, you can see the C-arm images of the acetabulum which was done. And this was the immediate post-op which I got it done. The limb length discrepancy was not there. And this is after 6 weeks along with the X-ray, and we started patient to walk on elbow crutch. This is after 2.5 months. This video has been shown by consent of the patient. There are good abductor power, and the patient is walking comfortably with elbow crutch. Take-home message is plan, plan, and plan. Because if you don't plan properly, you might fail. Always discuss with your mentors, and don't hesitate in asking stupid questions as well. They are the best judge on how to go ahead. Soft tissue handling should be with care, and don't shy away from using intra or fluoroscopy. Thank you.
Good presentation, Aditya.
Thank you, sir.
Just a few questions. When did you first see the patient after the index surgery?
So almost after 1 year, after a year.
Year. So what were the thoughts? Can you put up that first X-ray?
Yeah, sure, sir. This was the X-ray which I got it done, and before that, this was the X-ray which patient had with them.
So this was done immediate post-op or
No,
just
sir,
before the patient
this was
came to
after
you?
a few days of post-operative, because patient had lost the X-rays, the fracture X-rays and the immediate post-op X-rays. This was after 3.5 months when she had started having pain over the right side. The index surgeon got it done, so this was the X-ray available over there.
So if the patient came to you 1 month after surgery with this picture, what would you
1
do?
year, sir, 1 month after.
If the
surgery.
patient,
Okay.
I'm putting another scenario.
Okay. Sir, I would be going ahead with I would removing the implant and going ahead with a salvage surgery, head salvage surgery with a PFN and along with a plate with or without bone graft.
Hi, good morning. Dr. Aditya here. Do you want to discuss the trauma part or arthroplasty part?
I'm questioning the approach to the patient. I'm not dividing into trauma or arthroplasty.
I'm asking Aditya. So, what should have been done in this case at this X-ray? You want to discuss about the trauma, and regarding the arthroplasty, a nicely managed surgery. Why didn't you plate or fix the GT, which you left in the revision arthroplasty surgery?
So
One thing. Second thing, I think you used an 8-inch stem.
10 inches.
That was 10. I think that's a curved stem.
Curved stem,
available.
both stem.
Okay. Still you got a splinter in the diaphyseal region.
Yes, sir.
So this is the company, guys. What I have seen so many times with the solution stem, the proximal part is so broad. Most of the time it causes splinter at the LT level.
True.
So that's the basic problem with the solution stem. This is to Dhanshekara sir. What is your saying over using COCR long stems in long run? Because now there are publications coming, because of stress shielding there is osteolysis of the bone in long run.
So this fully porocoated cobalt chrome stems are very stiff and cause a lot of proximal stress shielding. So we have moved to titanium stems. Solution stem we use in a very elderly patient with a very small offset, because other stems have a very high offset. They are all European stems. They have very high offset. So elderly, low demand patients with a small offset, I use fully poro-coated cobalt chrome stems. Otherwise, we moved to titanium stems.
So titanium are far better than COCR.
Yeah. So this proximal splintering does not matter. If you are able to get a distal diaphyseal fixation, the proximal opening up doesn't matter. So just wire it and then we can leave it alone. It will osteointegrate. Before we move on, what are the ESR CRP for this patient?
Sir, absolutely normal. Sir.
Normal.
Yes, sir. I got the infective pathology ruled out first, and then even during the implant removal stage, I sent it for culture and histopathological
So
examination.
during your implant removal stage, you fix the GT.
So
Which normally we
with
won't
TBW
do
added.
because we are leaving a metal,
Yes, sir.
inside. So
Yes, sir.
that part we won't do.
Okay, sir.
The other way, we will be fixing it during the actual arthroplasty.
All right,
We
sir.
won't leave it hanging.
Sir, I was apprehensive that the abductors might, like the GT might pull away.
Yeah, but anyway, better not to leave metalware, exposed metalware
All right,
inside. So that part, then this 10 inches stem you
10
use.
inches stem. Sir.
Okay.
Just a quick addition to that comment on the solution stem.
Yes.
Solution stem philosophy is fit and fill.
Yes.
Okay, so that's an extensively porous coated stem that caused a lot of proximal offloading, as Dhansekhar rightly put. And I think people are moving a little away from that philosophy. Now it's going on to the titanium.
Yes.
Wagner type of spline flip.
Yes.
It's a tapered stem. Yes, the only drawback is it's a straight
Straight
stem,
stem.
but because it's tapered, you tend to be able to not go cause problems with the anterior cortex. And that is because it's coming back on full circle. If you look at the Wagner follow-up, the proximal integration also is very good. It's a very good stable stem, and people are moving away from the fit and fill philosophy to this type of fixation because it's not giving you the problems of a modular, it's a monoblock, and it gives you the offset and all the considerations that benefit this type of fixation.
With straight stems, what I have felt in older patients especially, they have bowed femurs. So distal part of the stem is
So that's
always
what-
abutting the lateral and anterior cortex.
two things that he very rightly emphasized.
Yes.
One is prophylactic wearing
Yes.
before you start the distal preparation. Number two, be judicious in your reaming. And there, like I said, a Wagner with a tapered stem will not cause you a problem if you go it
So
properly.
what I have seen-
You can ask Professor
Dr. Aditya,
Anila Road.
Yeah, any finding which makes you more suspicious of infection in this case. If you see the proximal part of the femur, at the fracture site, there is endorsal scalloping on the medial cortex.
Yes, sir.
This kind of finding goes more in favor of infection.
Infected.
You might have not grown anything on culture maybe.
Nothing was there.
That I think there was early probably implant in the fracture field. You do not rely on frozen section. You'd rather take it. I think that is a very, very good call to take it 2-stage. That's the safest way to go rather than, especially when you're having borderline CRP, SR and intraoperative findings that are suggestive of some collection.
Great. Thank you, sir. Thank you.
I think just I would like to make a comment. So probably the scalloping, the endosteal reaction was because the implant was going for a failure.
Yes, yes.
So if you look at there's a periosteal reaction as well near these two. So it was going to fail sooner or later. So
Yeah.
that bone reaction was probably secondary to that small loosening there.
Aditya, when will you consider dual mobility? So this is typically indicated when your abductors are suspicious. Better have a dual mobility socket to increase the jump distance and reduce the risk of dislocation.
Dislocation.
So if you're happy with the trochanter and the soft tissues,
Yeah,
then
that is a balance between if you've restored the horizontal offset well, she's a young lady, physiologically young lady, and if you've got a good abductor tension, no worry. But slightly, that's a very valid point, if it's a slightly older lady who has already compromised abductor, you said the GT was already not united and you're wiring it back. So all that in a slightly older, physiologically less active lady, definitely the first choice will be a dual movement.
All right.
But good case, well done.
Thank you, sir.
Any more questions? We can go to the next case.
Next.
Good morning, and thank you very much, Prasad sir, for giving me an opportunity to present this case here. And I'm grateful to be presenting this in this August gathering. This is a case of total hip replacement done for a acetabular fracture fixation done using a bone allograft. So this was a 65-year-old male, non-diabetic, non-hypertensive, had a history of road traffic accident and sustained injury to his left hip region. And in his history, we could just know that it was a fracture dislocation of the hip. The classification, the Thompson-Epstein type 2 that I've written over here is based on the further records that we had with him. And he was operated in another hospital, and some plates and screws were put there. He started weight bearing after around 3 months of index surgery. So 6 months later, after the index surgery, he presents to us with history of pain, limp, inability to walk without support, restricted range of movement of his hip, and with the history of massages and native treatment taken so that he can have his hip with good movement. So we got an X-ray done, and this is what was the first thing that came to us. And I could not see the head, so I was, it was taken aback, where did the head go? So the first things that came into my mind was that somebody has already done a surgery, attempted a total hip here, and then abandoned it. So maybe he's undergone 2 surgeries when the patient is not accepting it. So we just grilled the patient again and tried finding out what has happened. So I asked him to bring his old records also again, to bring back all the CT scans and everything that have happened during the index surgery. So this was his presenting gait. And since we had a doubt till we get the old records, I asked for a fresh CT scan of the hip. This CT scan, when we got it done, we could see a large deficient posterior wall starting from 11 o'clock to around 5 o'clock, and similarly, the implant was right in the middle of the acetabulum, and we could not see any portion of the head anywhere in any of the cuts. So when we got the old records, the first thing we saw was that was a Thompson-Epstein type 2 injury with a large posterior fragment, and this was the cuts, and as we can see, it's a large big fragment. So this was the first post-index surgery X-ray. There was a fixation done, plate was there, head was there, but suddenly it disappeared. And this is all happening within 6 months of injury and fixation. So before going for surgery, we just went ahead, aspirated the hip, sent it for culture sensitivity and everything. They were all negative, all inflammatory markers were normal. So we planned that we will go ahead and replace the hip and fix it. We gave the option of using of the trabecular metal, but since the patient was not very affording, so we decided we'll go ahead with the allograft. And then procuring the allograft was an issue, so we had to wait for some time before we could procure it from a bone bank. And we had asked for a bulk femoral head graft. So it took us some time to get it. So before going in for surgery, we planned a general anesthesia and extensile cochlear Langenbach approach, removal of the obstructing portion of the implant because we were expecting a lot of fibrosis here, and bone graft was planned. So while going into the surgery, we had in mind that there would be extensive fibrosis that we'd be coming across. There was definitely a risk to the sciatic nerve, and the metal implant was within the joint, so we thought we'll just go with whatever is coming in our way and we'll not go behind the implant. And the defect was definitely from 11 o'clock to 5 o'clock, so we needed a good coverage, and our prime intention was to have a good coverage for the acetabulum with the native bone as well as the allograft. So we went ahead, fixed it. This is the immediate post-op X-ray, and 6 months later. We fixed it with screws and with the allograft. Used a multi-hole gription cup with 2 superior screws and 1 inferior screw. And this is the post-operative gait of the same patient 6 months post-surgery, sir. Thank you.
Good case, well done. What is your last follow-up with this patient?
So this is 6 months follow-up.
You got a 6-month X-ray?
Yeah.
X-ray?
Yeah, that's
That's a 6-month X-ray.
6 months X-ray, sir.
Okay. When you said 11 to 5 o'clock defect,
Yes, sir.
you fixed the head as in terms of a hemispherical augment, and how much was your contact of the cup with the host bone? That is what is important.
Yes, sir.
Because how
That
much
is
was
what-
in contact
sir,
with the aloe and how much was in contact with the
Two
host bone?
things that we have done here is, if we see the X-ray, we have used a smaller cup here. It's a smaller cup. We didn't want to over-ream things. We wanted most of the host bone to be there. And on top of it, we wanted just more than 30 to 40% of the allograft coverage. Means the allograft should be covering only 30 to 40% of the cup and more than 60% in the host bone. So we've used a smaller cup. This is 48 cup with 28 head to fix
So,
it.
yeah, I noticed that you had put a plate to fix the aloe, correct?
No, no, sir.
That was a residual plate.
This is the residual plate. We've cut the plate.
So how did you anchor the allograft to the rest of the column?
Sir, I've used two screws, sir.
2 screws.
Two screws in each. The longer screws that you see in the middle, sir, they are fixing the allograft, sir.
So do you have a lateral view for us to, because
No,
that
sir,
would be,
I don't have a lateral
You
view
don't
because
have
this
a-
patient is somewhere, getting the X-rays out of him is a difficult thing. He just lost all those things.
So I'm worried about the femoral stem. It's in slight varus, looks like slightly undersized. It's only 6 months down the line, so that is also a
Yes, sir.
suspicion.
Definitely, there is the stem is small.
And,
We did realize it after our post-operative X-ray, and slightly into varus in the initial X-ray, but when we took it after 6 months, it didn't look like much of an varus. So
what is the size? This is a corail, I presume?
it's a corel, sir.
What is the size of the stem?
So this is size 8.
Size 8. So as a general rule, what was the size of the cup and what was his body weight?
His body weight is around 60 kgs, sir.
Correct. So what happens is, corail has this problem where you have potting,
Yes.
where you do not have the stem sinking down sometimes. You need to ream the canal. Especially, I'm sure you would have got a very tight fit with 8.
Did we?
Sometimes you have to use some straight reamers to open it up so that it doesn't hold distally and cause a little bit of toggle proximally.
Yes.
That happens that's what we are trying to say in long. So sometimes you got to ream it, template it properly.
Yes, sir.
And probably you might have been able to seat a 9 or a 10
Yes, sir.
better.
Yes, sir. Definitely, definitely.
Any comments from the floor? Any questions? Yes. I think so. That's what, we don't know whether,
But usually post...
correct, the LT is at, the neck cut looks a little higher, and that's why I wanted this is a 6-month X-ray?
Yes, sir. 6 months. Yes.
So what I can't see is the top of the pelvis, so I cannot comment whether there's a slight tilt also, but if your his gait seemed to be okay, so I'm not sure whether the lengthening is...
No, sir. There was no lengthening as such.
Can you go back to the initial CT, dislocation CT? So that will give you a clue about what is the bone, yeah, this one. So the extent of bone available for reconstruction. So you can see the inferiorly there is some bone. Now you said it is 11 to 5. So below that there is some fixation available. And superiorly probably 12 o'clock you have a bone available. I think primarily it is...
This is the CT after the injury.
I know.
And this CT is just before the surgery. So when we took that, there was something from 11 o'clock, we can see a deficiency right down.
So from probably 12 o'clock to 6 o'clock, you have some fixation. So
Yes, some
primarily,
fixation.
the cup is stable even without allograft. The allograft will be going to be useful for reconstruction of the bone.
Yes, sir.
So cup side, I'm not worried. Most of the time, acetabular failed fixation. If there is 2-point fixation, 3-point fixation available,
Yes, sir.
it's going to incorporate.
Yes, sir.
I
I've
think
taken
this
the
will-
3-point fixation.
This will heal, but 6 months is too short a follow-up.
Yes, sir.
Probably you have to wait for 1 to 1.5 years to actually see.
Yes.
And probably need a CT to see actually whether the allograft is incorporated.
Sure, definitely.
I think femoral side is a little bit suspect. That's
Yes,
the only
femoral
worry.
side.
Good, otherwise you maintain host bone, respected principles.
Yes.
Good presentation.
Thank you, sir.
We'll have the next case. Yes, Dr. Chatterjee.
History of missing head.
Yeah.
So the mystery of the missing head, so we also don't know, he doesn't give any history of any other surgery. His incision was only a single incision, no double incisions.
So he showed
it
an
is
immediate-
basically, most probably it's the plate which is the culprit, that was I suspected, sir.
No, they
there was a
probably.
But it looks like such a clean cut. That's
Yes.
such a clean cut.
That was the
so,
missing.
so that is the only
Such a clean cut.
only thing is whether AVN set in so fast. Again, not a possibility. Only other possibility is a low grade infection, which he said that is ruled out. But apart from that,
Clean
the
cut,
condyle,
yeah.
it's a clean cut. So
It's a clean cut. It's a,
Yeah.
So when
Sir-
you, the only question is when you opened the fracture or
Yes,
when you
sir.
opened it to do a hip,
yes, sir.
how was the surface of the neck? Because I noticed you did not probably, and that's why the comment on lengthening also. Did you revise the neck cut?
Yes, sir. We have
You
revised the
revised
neck.
the neck cut.
Revised the
So
neck cut.
what-
There were like pieces of cartilage inside the joint.
No. We're
And
talking about the
this
surface
neck was
of-
smooth.
the surface of the neck was
Smooth,
absolutely
yeah, closed and smooth.
Yes. So, correct. That is what, even when we saw the first X-ray, we thought somebody had tried to do a THR.
Yeah, even when I saw the first X-ray after this thing, this thing was somebody tried to do a primary total up and abandoned the procedure. That was the thing that came into my mind.
Can you show the immediate post-op X-ray?
There is a history of massage actually
X-ray?
of 2 or 3 months.
First
In severe
index
massage, head tends to disappear.
And that's why we tried to find out.
No, you said with massage, head tend to disappear. You said with massage.
History of manipulation and massage for 6 months.
Yes.
Yeah, probably AVN, and he's been walking on this neck, so that
Yes,
is
sir.
causing a smooth surface probably.
Smooth surface.
AVN usually head disappears within 3 months or 6 months. Post dislocation with
We don't
acetabular
have a
fracture.
proper view here. We don't know how much of head damage occurred with the initial injury, with the attempt at fixation, condyle damage. So I guess you don't have much more information on that.
No, sir. The only CTs and things which were available were these only, sir. That too after
Can I
constant
ask one
drilling.
question?
Yes.
Why there is a need of allograft? Because the acetabulum was properly shaped in a shape, and there was only the posterior wall was defect. So it can be compensated by allograft or anything.
Sir, it can be compensated by iliac graft, yes, definitely, sir. But we thought we'll put a allograft, it will be much more easier, not going in for iliac. We didn't consider iliac actually.
The complication, if you compare the complication of autoiliac and the allograft, so I think this allograft is better option.
No,
No,
definitely.
irradiated allograft is good. They don't
It's
have
good.
major problems. Yeah.
I think definitely the allograft is better, but in case if he is suspicious about that, he is not getting the entire bulk of bone which he wanted to at the time of
An
surgery,
iliac
he is
graft-
not going to compromise
Exactly.
at that moment of time.
That
was
was
the
I
basic
mean.
reason he did it.
Plus the amount of graft that might be required because it was a very large defect in the posterior wall, right from 12 to 5. So there, if you have to take out the iliac, how much I'm going to harvest there?
Okay, request
Dr. Dharmendra, for the next case presentation, if you
Thank you,
can
sir.
get ready.
Thank you.
Good presentation. I think that concern about the allograft is right because we have also seen that allograft tends to collapse delayed. There is a delayed collapse. And that is what we need to be worried about. You don't see that at 1 year, 2 years. By Dr. Dharmendra gets ready, we just make these few comments. So allograft, as rightly said, I think somebody brought up that point. If you have adequate host bone and you're using a multi-hole cup with about 50, 60%, and you have the buttress residual, you can use a smaller cup, make use of the native bone, then you probably can make sure, even that's why I asked, did you revise the neck cut? Even that can be put off as graft, and you can use an iliac crest. Only in cases where you really need to, you can go to an allograft. Because allo, especially when you use it as a bulk, it can survive long, but the problem is after 7 to 8 years, you may see a little collapse, and that is what is worrying.
It's very dicey in long term.
that bone available to put a socket. So you have to put your socket in the native acetabulum. You calculate the length you need to bring it down. So if the length you need to bring it down is beyond 4 centimeter, there is a risk of sciatic nerve palsy. So you need to calculate your subtrochanteric shortening osteotomy. So the same thing has been done for healing. There's one more patient, type 4, Crow type 4, 60-year-old lady, compensatory knee valgus deformity. Again, we plan a very low socket in the anatomical position. It's not moving. So it's very helpful in deciding your plan of the socket. You can see there is no socket on the left side. There is no socket developed because the hip has been outside for a quite long time. So here again we need to plan a subtrochanteric shortening osteotomy. So you put the sleeve, try to do the osteotomy, reduce the hip into the socket, and pull the leg and see how much there is overlap. The overlapping portion has to be removed. So you prepare the stem portion, ream for the sleeve, you put your sleeve inside, do the osteotomy, do a reduction, and then you do a shortening. So here there is no good cancellous bones, so I had to ream. There are no superolateral buttress available for press fit, so I used a cemented socket. At follow-up healing of the subtrochanteric osteotomy. So Crow type 4, there is no false acetabulum. Anatomical acetabulum placement has to be followed. Use a small micro cup. You should not breach the columns. If you are not careful enough, the thin columns will be breached and you will lose your fixation. Femoral osteotomy, more than 4 centimeter lengthening will cause sciatic nerve palsy. So subtrochanteric shortening osteotomy prevents nerve palsy and also will allow you to correct the version. So you can change the version when you are doing your subtrochanteric shortening osteotomy. Cemented stem also has been used for subtrochanteric osteotomy. You need to plate it with a small 3.5 compression plate and you can still cement it. Good outcome has been reported. But in the acetabular side, cemented fixation has very high failure rates. So now we go for a small poro-coated cup. This is an example of a patient who presented to me with a failed THR. If you look back the original X-ray, it is a Crow type 2 hip replacement done in 2004. So here the mistake they did not medialize the socket. They did not get good adequate superolateral coverage. So it failed in 6 years. So it presented to me in 2016. You can see the 3D CT, there is a socket below the actual cup. The native socket is still there. So the CT gives you an idea how much you can medialize. So if you are starting to do a dysplastic THR, you can do a CT sections and see how much host bone is available, how much you can medialize, what is the exact size of the cup you can use. So here we have good medial bone available. So I removed both the socket was loose, stem was a non-modular, Chanley type of stem, 22 head. So I had to revise that also. You can see the acetabular socket, they never reamed it enough, so it's a flat socket. So I need to identify the socket with the image intensifier, reamed it, created a socket there, put an uncemented cup. I could have gone a little bit medial, but I was worried about losing the superolateral buttress we are discussing. So used a modular stem with a proximal fixed loading stem. Very important thing is restore your combined antiversion angle. So it has to be properly restored. 30 to 40 degrees of combined antiversion angle should be restored. Otherwise the hip is going to dislocate because of the small head. And if you use a 22 head and a 44 cup, the number of modularities also comes down. You have 1 or 2 sizes to balance the hip. So you need to be very meticulous while doing this surgery. The superolateral coverage has been reconstructed with the allograft. This is the final image, and subsequently the left hip also was replaced, and that is like a primary Crow type 1. Right side is Crow type 2, but it's a revision. So conclude, DDH is one of the most challenging problems in hip surgeons will face. Total hip replacement gives excellent results. So you need to have small micro cups and modular stem, and meticulous planning and good surgical technique will give excellent results. Thank you.
Thank you, Dr. Dhansekhar, for a wonderful presentation. Any inquisitions from the house? Before that, sir, how much do you have to struggle with the soft tissues while doing all this? Because that is one of the most difficult problems sometimes we feel doing a dysplastic hip. What's your experience about it?
So in Crow type 1, 2 and 3, it's not a major issue.
Right, sir.
Crow type 4 is the one where hip is totally subluxed and there is gross shortening. So we clinically see the patient, we do a telescopy and see how much the hip is, we are able to pull it down. Then before positioning the patient, we do a adductor tenotomy routinely. Okay. So that's it before the positioning itself. The structures we release the IT band, the complete capsulectomy has to be done. Then IT band and some amount of gluteus we erase from the ilium. Yes. So these are the structures we release.
Yes. Yeah. That is the basic message which I wanted to pass to the house, that this is the... Any opinion of Dr. Oman?
But we don't do an extensive soft tissue release now because we are able to do a good subtrochanteric shortening osteotomy. We counsel the patient that limb length will not be restored. He needs to continue to use a heel and sole raise. We try to preserve the soft tissue as much as possible so that we prevent dislocation.
You have to be judicious enough in deciding in between the two.
Yes.
In addition to the posterior release, which was nicely elaborated by Dr. Dhansekhar, I think there's also the role, especially to restore the offset. The anterior capsule has to be released very effectively, and that has to be done very close to the... So that is one thing that will enable you to at least mobilize the femur also, and also facilitate your reduction, because most of them have already been contracted, and the anterior soft tissues are really contracted. So when we go posteriorly, that anterior capsule has to be raised off from the acetabulum and also from the femur in order to be able to get an effective reduction, then do your osteotomy, and then in addition to the posterior release.
Right, wonderfully depicted. Any other inquisition from the house?
Professor Anil, yes.
Mike, sir.
I use a mostly lateral approach. My primary approach is anterolateral hard hinge.
Yeah, there's beneficial, you know.
Yeah, yes.
In these difficult cases that you can see the anterior column.
Yes.
And you can see how much thickness is left.
Yes.
And you can be very judicious.
Yes.
So especially in these cases, I found out lateral approach is very, very beneficial.
Yes.
You can even see the tendon of iliopsoas going.
Yes, yes.
So that approach matters a lot in these cases.
Yeah, but the revision case I went posterior because I don't know whether the posterior column was there. But primarily I use a modified hard hinge. It's very useful.
Yeah, I think
Crow is better posterior.
most of the points have been covered, but just one or two things that in the Crow type 4, you need to really actually create a soft tissue sleeve and go all around it. You really must see the acetabulum well, and it is this that will actually give you a lot of stability and coverage when you eventually start closing. The second thing is regarding the osteotomy, it is almost always required in a Crow type 4.
Yes.
The important thing here is please don't over-shorten the osteotomy. There's a tendency to do that. So if you over-shorten, then this hip will again dislocate.
Yeah.
So you have to first reduce the proximal fragment, and when you resect bone from the distal fragment, do it about 3 or 4 millimeter less.
Correct.
So that, So otherwise, I've burnt my hands. When I've done exactly, it looks very good on the table, and 3 months later, the patient comes with a dislocation. So you have to really make it very tight.
These are the late surprises which you get sometimes.
Yeah. The third thing is that this is one of the very rare situations where you actually have to retrovert instead of antiverting. And retrovert and create the lateral offset. If you so that's why the SROM is useful, because it gives you many options in the lateral offset and the vertical offset. And you can have you can use calcar sparing once in a while, although most of the time you don't need it because it's already very tight. So this
you get the per-operative versatility with SROM.
I think that's a very valid point you brought about the osteotomy, because if you look at the, we've all seen that, especially in the small cups, you have only a 22 head. And if you look at the DPU 22, there's only one size available.
Yeah.
Okay. So that we have to be very careful, because what happens is, especially when you're doing the shortening, we have to, like BDC rightly said, reduce the proximal fragment in, look at the overlap by giving actual traction on the distal fragment. And I think what we don't hesitate to redo the osteotomy, we cut a little less, do a trial reduction again, see whether the soft tissue is okay, if necessary, because once you're overdone your shortening, we don't have another trial, we don't have another neck length to go to. So I think it's very useful tip that we have to redo the shortening if required, number one. And the big benefit of the SROM is that it has a 30 and the 36. Most of these, the offsets are inherently low. If you suddenly restore the offset to a larger offset, what happens is the greater trochanter can avulse. And that is a big problem intraoperatively. Right. So it's better to try with the SROM 30 and go do the release, try with the 30. Very, very often the 30 is adequate, and as was rightly demonstrated by him also, and that's a big advantage with the SROM. Version can be corrected, your offset is also the lower, inherently lower offset, and also you can use these things. And I think the big note to make is, you're shortening osteotomy, don't hesitate to do it 2-3 times so that you get the optimal length. And do not lose soft tissue tension and land up with a situation with dislocation.
Thank you.
Sir, in a Crow type 4, when we are doing the subcrow osteotomy, should we fix it with the plate to prevent the rotational
component, because non-union cases are also reported at that osteotomy site?
Depends on your diaphysis. If there's a metadiaphyseal mismatch, your diaphysis is quite big, and you're putting a thin stem, then you need to plate it. If your diaphyseal fixation is good, because your size of your sleeve decides your stem. The stem size is not decided by the patient's diaphysis. So you can go only to the maximum size sleeve which will allow, then corresponding stem only you're going to put. So if it's a large canal, then we need to plate it. For all these patients, the canal was small, so I was able to manage with just stem fixation alone. But if the canal is quite wide and you're putting a very small sleeve and a small stem, better to plate it.
I just want to add to that these stems are typically funnel shaped. So you have a pretty large sleeve going in with a very narrow stem. And if you think about the SROM configuration, the smaller the stem, the smaller are the flutes. So there is again, a problem of the flutes not engaging sufficiently with the distal stem. And then there is a rotatory sort of instability, and then that can lead to a non-union. So yes, I think you should keep a plate handy. And every once in a while, you might want to put the plate to ensure, to give it rotatory stability.
Omen, your comments.
We have a small tip for that. We had actually done this in the sense we have published a series of shortening osteotomies. So initially we had to put a plate. Then we realized after you do the shortening osteotomy, suddenly the canal actually becomes wider beyond the site of osteotomy. So what we do is we go back to preparation. Prepare the distal of the SROM. Yes, it is a little troublesome to hold the proximal. Prepare it again. You might be surprised you'll take one size larger. And that gives you that additional rotational stability. So if, like you said, if it's a very small one, then there's no room. But if it is a larger size where the canal is already widened out, that is one possibility where you can re-prepare that. And the SROM, the distal reaming, in this particular situation, don't ream 0.5 more. Ream the same size. Get the actual fit so that, like we said, you get a snug fit. Do your trial. Trial will give you no clue of the stability because the trial is rounded. The splines come in only with the actual implant. So I think the best assessment there is once we finish the osteotomy, go with the trial reamer again, see how it is. And I think we can go one size higher. We get an absolutely stable fit. You can do away with the plate. That is the best solution.
Always have a 3.5 locking plate available. Just contour it
just
and
in case. Yeah. But once we've started doing this, we have almost never used a plate for all our shortening osteotomy. And we put in our series also. Yeah.
A very basic question. Is there any role of pre-operative skeletal traction for a few days in these cases?
There is no role. There is no role. Yeah.
Okay, thank you.
Sir, I have a question.
Now,
sir, I have a question, please, sir. Sir, I have a question, sir, please. Particularly in distal plastic, it's very difficult to find out the true acetabulum. Once you find it in a CM, but how you proceed during reaming? Most of the time, it's very difficult to maintain that position while preparing the acetabulum. So how you proceed for the true acetabulum while reaming?
So you put a Steinman pin and locate your...
I have located, but while you're reaming, it's very difficult to maintain that position while reaming. It's mostly you go up and posteriorly while you start reaming.
You go vertical. You take a small reamer, go vertical the point where you put your Steinman pin. So you're trying to ream at 45 degrees and 15 degree anti-ovation, it will skive away. So just take a smaller reamer, 38 reamer, create a small starting point. From there you change and keep going.
Okay. Thank you.
Yeah.
Okay. Sir, hello. Instead of doing transverse osteotomy, if we do step cut osteotomy, chances of non-union and rotary instability will be less.
Definitely, but it's not easy to do it. Transverse is very easy.
How will you check the rotation then?
Yeah.
Now, thank you, Dhansekhar. Second, Dr. B.D. Chatterjee. The cemented THR. I think cemented THR is like a permanent lipstick. Once you apply it, very difficult to remove it. And there are many shades of it also.
Hello. Hello. Am I audible? Yeah. So, Honorable Chairman, Chairpersons, respected senior colleagues, and my dear friends, this is a moment of great privilege and honor for me, and sincere is something like a lost art, actually. It's people are moving, further away from this technique, and what we have see today is a big predominance of non-cemented THR. So I'm really having to talk about something which is almost becoming historic. But if you look at it, Sir John Charnley's low friction arthroplasty was actually a cemented arthroplasty. And if you see even today cases done by very, very senior and reputed surgeons, the Charnley's implants are still lasting. So it's not something that really needs to be thrown into the waste bin. Oh, okay. I don't know, we can hide this actually. I was doing something with arthroplasty. Now, in order to be able to successfully perform cemented arthroplasty, I think we need to understand what is bone cement, and also get rid of a lot of myths which go along with it. There are various types of cement, and they're classified according to their viscosity and their ability to flow. So more viscous the cement, the less is the flow, and you need to actually handle it with manually, which is called the digital. So that's CMW1, which is a high viscosity cement. The CMW2 is again a high viscosity cement, but it is fast setting, and these two are really actually suitable for your acetabular fixation, but not so much the femoral side. So what you need for the femoral side is a low viscosity or a medium viscosity cement, which can be used in a syringe, and which actually requires to be compressed and pressurized and this is ideally suited for the femoral shaft. Please understand that bone cement is not a glue, it is actually a grout. And this is something you need to understand. It will not stick your implant together. And the methodology by which this cement functions is the phenomenon of interdigitation. So the cement flows into the cracks and crevices of bone, and that's how it gets its solidity. So it is important, therefore, to pressurize this cement in order to get a good fixity. Now, therefore, this is a picture, I think, which very clearly shows how the cement has moved into the cracks and crevices, the intertrabecular spaces, and that's what gives it stability. Now, there's also very important to pay attention to this cement mantle. And if you look at literature, then you will see that about a 2 to 4 or about a 3 to 5 millimeter cement mantle is necessary for providing lasting fixation of cemented devices. Now, one of the major reasons why cemented THRs have gone out of vogue is the fact that it is highly technique dependent. It's a demanding technique, and unless you do it perfectly, you will have suboptimal results. So the technique of cementing has undergone changes over the years. So we started with Charnley's first generation technique, which was just a simple mixing in the bowl, and it was introduced with the hand, and it was just compressed, and the implants were put in. And this was modified by Ling in the second generation cementing, where there was a lot of emphasis on preparing the bone bed. It has to be free of blood, and it has to be dry, and you need to have a cement restrictor to enable you to actually compress or pressurize the cement inside the medullary canal. And the modern cementing technique is really a mixture of these two types, the first generation and second generation techniques, and some of the salient features are sort of listed there. Now, what about the survivorship? Now, if you look at the 20-year survivorship this paper by Callaghan, quite a famous paper actually, and it's some years old. So 97% on the femoral side and 90% on the acetabular side, and I don't think a lot of cementless systems can actually challenge that. So as far as results are concerned, a well-performed cemented hip, there is really nothing to worry. And, but again, as I said, it is the cementing technique which plays a major role in the survivorship of these implants. And you can see from this graph that the modern cementing technique has nearly 100% survivorship, whereas the first generation sort of tends to fall away after about 10 years. Now in the acetabulum, this is just a little bit a quick brief about the technique. So you need to pressurize it, and again, you see 20-year survival in this paper of 90% in the acetabulum, which is, I think, very good by any standards. Now on the femoral side, you need to put the restrictor first, and then you need to pulse lavage and clean out and remove all the debris from the canal. Use a cement gun with a pressurizing attachment, and then you sort of fill it up and then put in the stem. Now, obviously, survivorship is a worry in THR, and the problem is of osteolysis and implant loosening, as you can see in this picture. And this is particle-induced osteolysis. Now, unfortunately, cement was blamed for this, and it got a bad name, and it was actually called cement disease. So everybody sort of, shied away from bone cement. It was only later that we came to know that the real culprit was the plastic. And it was this polyethylene wear which actually caused this osteolysis. And ever since this has been replaced by the highly cross-linked polyethylene, this problem of wear has actually been handled to a large extent. Now this is a picture of the well-done cemented total hip. And what you can see here is the white out sign. So you really cannot see a differentiating lytic division between the implant cement and cement bone interface. And you can see this is what your post-operative X-ray should look like, both on the socket and the femoral side. And this is an example of the longevity of such an implant. What you see there is the old Charnley technique of doing a trochanteric osteotomy and then wiring it back. Most of the time we don't do that because we have more modularity available even in cemented implants today. And you can see from this that the bone cement mantle lasts almost forever. So in the present scenario, how will you select your cases for cemented techniques? So some of the indicators are presence of osteoporosis. If you have a wide medullary canal, a Dor type 3 canal, rheumatoid, sometimes difficult to do a non-cemented impaction. If you want to use the technique of impaction bone grafting, I'll show you some examples of this. Or if you want to use an acetabular cage, which was alluded to by the earlier speakers, that once you put the cage usually goes in very vertically, and then you will actually need to cement a socket in with the proper abduction angle and proper version. The impaction bone grafting technique, again, is a very, very useful adjunct. It can be done on the acetabular as well as the femoral side. So you put morcellized chips and you sort of impact them, and you can actually then cement and use it. Now here you can see a tantalum sort of mesh has been used, which is sometimes required in very, very extensive defects. So I will show you a series of cases which are not the straightforward simple primary cases, which obviously are very amenable to cemented THR, but I will show you some slightly unusual cases where you might think that it's difficult to get away with a cemented hip, but then I can show you that how good results can be offered in these. Now this is an elderly housewife who had a fall and was not treated, and what you can see is a post-traumatic severe protrusio, and when we opened up there was a huge defect, and this was treated by impaction bone grafting. This is what we, after the reconstruction, you see we needed a tantalum mesh on the posterior superior corner, and then the whole defect was bone grafted, and it took a cemented socket, and as you can see, a very satisfactory post-operative X-ray. Now, this is another example of a post-traumatic protrusio with a central type of dislocation in this Obviously, the non-cemented option is very much there, but here we decided to do a cemented treatment with impaction bone grafting because the head of the femur was available. So the autograft was used, and then the cement was applied, compressed, and a cemented socket went in, the cemented stem, and you can see at the tip, that's the cement restrictor at the bottom, and the centralizer, which is attached to the tip of the stem. So again, a very satisfactory outcome in a somewhat complex primary. This is, we saw many of these today, also today. This is fairly common, a failed DHS with completely, with a acetabulum which has been affected. And here, of course, the SROM stem was used because there was a version problem. But on the socket side, we decided to use a cemented socket with very satisfactory results. Sometimes, you know, in these osteoporotic situations, this is a very good bailout option. Again, a scenario which we very frequently encounter in our country because of suboptimal use of suboptimal implants in osteoporotic bone. This is a severe protrusio in a sort of fixed bearing bipolar implant. And again, this patient had a significant osteoporosis. The only way of doing it was a cemented stem with a cemented socket. This is another advanced rheumatoid with severe protrusio and a loss of lateral offset here. The acetabulum was deficient, so this needed a cage. And as you can see, the cage goes in quite vertically. But if you want to correct that abduction angle, you can actually cement a socket in the correct degree of abduction and the correct version. So again, an example of a cemented socket, and what we have used here is also a cemented stem because of the severe osteoporosis in this case of RA. Now, cemented revisions also can be done in this. Again, this was a pelvic discontinuity which needed a cage. We did an acetabular revision here, cage and a cemented socket. This is another example of rheumatoid arthritis with bilateral hip involvement. You can see that there is obvious osteoporosis. And again, this was treated with a modular cemented stem and a cemented socket, bilateral hips done, and again with a satisfactory outcome. Failed hemiarthroplasty, very common scenario in all our practice here. And here you can see this has again been managed because with a cemented stem and a cemented socket. So in these revision situations too, you can actually get away with cemented implants. Again, a case of rheumatoid arthritis, severe protrusio, osteoporotic bone. You can look at the thin cortices, managed with this with a modular cemented stem and a cemented socket. So again, a failed Thompson prosthesis. Again, if you have a good Moreland instrumentation, you don't need to do an ETO in these cases. You can actually manage to take out all the bone cement. The other option is that we have the so-called cement in cement technique. So if you have a very solid cement mantle, you don't need to actually remove it. You can again cement in on top and put in a thinner stem. So this was again managed with a cemented hip. Yet another example of failed hemiarthroplasty converted to a cemented total hip system. This is another example. I'm sure all of you would see plenty of these cases here. Again, a failed hemiarthroplasty. Coming to slightly more complex situations, you have the option of a cemented dual mobility socket. Now, this is an example of the dual mobility. In this case of vascular necrosis, you can use a dual mobility socket and a cemented stem. Dislocated hemiarthroplasty, the dual mobility cemented socket, and I can see again a very osteoporotic patient, elderly, so you can use a cemented stem and a cemented socket. Hip arthritis following trauma, again dual mobility here because these are again prone for dislocations, and a cemented stem. We saw many of these today, the acetabular fracture, where again here you can actually put in a dual mobility cemented socket and a cemented stem. So this is the technique of impaction grafting, which has been, excellent survivorship has been reported, a very large series by GA et al. And even in the Swedish study, they found 94% survivorship in almost 1,500 cases. So here you use the collarless polished stems, and collared stems also can be used. And so what you do here is that you fill up the bone defect with either with mostly allograft, morselized allograft, and then you impact them with a special instrumentation system, and then you can fill in cement and actually perform the surgery. This is an example of failed isoelastic stem. This was a disastrous failure actually, and this has been revised by this impaction bone grafting technique with an Exeter kind of a stem, and a revision the socket has also been revised. What Dr. Dhanashekhara mentioned was extremely true, that this is really a very, very modular implant system. You can actually do any sort of version. You can reduce the vertical offset by pushing the stem down. You today have the variable lateral offset options. So this is again a very, very viable option here. This is again a failed cemented THR, and this is where we did the cement in cement technique with a revision, revised to a C stem. The socket side, of course, we have put in a non-cemented socket, but again a cement in cement technique for the revision stem. Tuberculosis of the hip, the first stage was a kind of a girdle stones was done because it was very, very osteoporotic with a lot of granulation tissue and bleeding, so we really couldn't put in an implant in the first place. But after about a month and a half of anti-tuberculous treatment, the situation improved a lot, and then we did a cemented stem. You can actually incorporate streptomycin in this bone cement in tuberculous hips, and the other X-ray is after about 3 years, which still shows a very good lasting of the implant. Another example of a tuberculous hip treated with a cemented implant. So again, this is again a situation where you can use a non-cemented system, but we decided to use a cemented system here. And you can see you have the long stem option in case you want a little more distal hold, which gives a pretty good outcome at the end. So this are some of the cases in different situations where you can actually employ a cemented technique with very satisfactory, gratifying results. And I thank you for a patient hearing.
Thank you, BD. Wonderful presentation, nicely depicted. Questions from the house. Before that, what do you think is the role of any pulse lavage by doing a cement? Sometimes.
So the problem with the cemented hip is that it is extremely technique dependent and somewhat unforgiving. So the enemy number one in cemented hips is blood.
Blood, yes.
So the first requirement, in my opinion, is hypotensive anesthesia. You need hypotensive anesthesia. Yes. You cannot do a good cementation in a oozy field full of pools. So you need hypotensive anesthesia. You need the pulse lavage. Absolutely, you need to wash it out. I use a bottle brush actually to sort of scrub out all the fat from the femoral canal, and you need to really dry it by packing with a gauze. You need to take time, and you need to pressurize the cement. So these are the real, very strict requirements for good cemented technique.
And this brush is wonderful. I have seen in Exeter even they are doing it.
Yes, a bottle brush.
Bottle brush. They were using it in Exeter course. Now, what is your take on the cement on cement?
Yeah, it's a very good technique. It is an easy technique. You tend to get out of difficult situations. It makes your job easier. The requirement is you need to look very, very carefully on the X-ray at the cement bone interface.
Yeah.
If there is no continuous lysis, then you know that the cement mantle is good, and you can use that. It gives excellent results. So in fact, I can tell you an instances where I've done the socket revision, and the Exeter stem I've just put it out and I've put it back.
Okay.
The hip, and it works perfectly.
Excellent cases, Dr. Chatterjee. Just my query about the head size. 28 head in all the cases you have used.
Yes.
Do you have found any problem in dislocation?
Well, no, not so far. Yes, that is a constraint, but Striker now has larger head sizes for their cemented sockets, so you can still use them. I think companies are coming out with two things have happened. One is the highly cross-linked poly is now available as cemented sockets, and you have larger head sizes, so you can do that. And you can easily adjust the the version by just rotating your stem, and this is a completely modular implant.
Okay, thank you.
Sir, how do you pressurize your cement when you are using a long cemented stem?
So the long cemented stem is a bit of a compromise. I agree that you really can't pressurize all the way down. It is a bit of a compromise. So there are actually very few situations where you will actually. But in the long stem, you see, it is a pretty large stem. It's a size 4. So if you can pressurize the cement even in the proximal part of the femur, and it's got a fairly large offset, you can actually get a pretty good rotatory stability from the proximal fixation. The distal fixation is not absolute, it is just an adjunct.
But if you are using cement in the liquid phase, then there are chances that it will go.
I know. I am a bit scared of filling up the medullary canal with cement. I think that's going a step too far. I don't know, maybe some other opinion here.
If you go by the strict philosophy, you got to have a whiteout. And pressurizing in the actual thing, you got to measure the actual stem, put a restrictor distal, use a gun, low viscosity cement, make sure it fills the canal, use a pressurizer that is available, because that is available.
Sir, I'm asking about using
a long stem, because the cement gun, the nozzle will go all the way down. Strictly speaking, you have to pressurize and create an even cement mantle. So you got to measure, make sure the distal cement mantle is not too long. You got to put the restrictor in such a way that the distal mantle is only about 1 to 2 centimeters, not more than that, and pressurize it with the cement gun. The pressurizers are available. You cut off the nozzle once you put in the thing, once you fill in the canal, use the pressurizer and press. And that is the best way you will get.
You see, it's almost impossible to use a pressurizer in a long stem, use a cement restrictor in a long stem, because you see the canal just goes and starts to widen as you go down. So if you push it all the way down, it will simply fall, into the supracondylar area. So effectively, you really can't use a cement restrictor there. So it is a compromise, but it tends to work.
And I think you use long stem even only in older patients, not in young patients at all. You're not that much worried as we are worried in a young patient about pressurization of cement.
Very nice presentation, Dr. Chatterjee. In this era of non-cemented hips, I think it is a very refreshing and revising cemented. On the acetabular side, in case of protrusor, what is the maximum thickness of cement mantle you will accept to make up that?
No, so cement mantle has been very clearly defined. If you read the papers, it is the minimum is 2 millimeters, the maximum is 5 millimeters. Please do not fill up your protrusio with cement. That's not a good idea. You have to make up the protrusio either with autografts or with allografts or with a cage.
So it is maximum 5.
2 to 5, that's what the literature says.
I think that should finish up. And now I would like to, just 2 points, just summarizing everything. When you talk about head size, don't forget the evidence. The series published as a follow-up Charlie series, which has worked tremendously well even after 30 years with a first generation cementing and 22 millimeter head. And friends, I have my patients whom I have done in 92, 93, 91. 92, 93, a couple of them are still surviving with 22 millimeter head. So that first generation cementing also worked. The bottom line is, whatever technique you follow it to the jet. There should not be any compromise here. The technique have to be followed well. And just Dr. Anil Oman was discussing, he is getting a follow-up 22 millimeter head. He is taking squatting and cross-legged X-rays, and he said they are very well covered. The 22 millimeter head is also well covered. What I see, I'll give it a take-home message, because what we see as a follow-up, when we are dealing with a large head, we forget about anything else. We are so relaxed that we fix the socket in any way we want. And that can lead to edge loading and the longevity is gone. Don't be complacent. The technique and the principles you cannot compromise because we are having a large head and you are very sure that it will not dislocate. No friends, it doesn't work that way. Learn about the technique in the long stem. You can play with your technique so that the concepts are not broken. That's all. Like in the long stem you are using, you can use a cement which is still in little more liquid form so that it goes there, but without restriction, you cannot use cement there. So these are some points which are very important as a take home, and I still think cemented stems are little more demanding definitely, but they are absolutely your lifesaver. You must learn that technique at any time. It's the biggest bailout procedure you have in your hand. Thank you. We go for the next session. We're already getting late.